Hi, everyone. My name is Joanna Tenkate, and welcome to this webinar. I work at Global Heart Hub as our Patient Community Engagement and Development Lead, and I'm very pleased that you could join us today. As many of you know, Global Heart Hub is an alliance of patient organizations and advocates working to create a unified global voice for those living with or affected by heart disease. And today, we are delighted to be partnering with Heart Valve Voice UK in support of our shared commitment to reaching and empowering the global patient community. Today, we're focusing on women and heart valve disease, a critical issue where gaps in diagnosis, treatment, and awareness continue to put women at risk. This webinar is also in line with the launch of Global Heart Hub's new report on women and heart valve disease, which we hope will spark important conversations and actions. Before we get started, just a quick housekeeping note. Automated translated captions are available in over 35 languages by clicking on the caption button, and today's webinar is being recorded so we can share it with those who couldn't attend live. And with that, I'm going to very quickly introduce our speakers who will be covering this important issue. We are joined by leading cardiologist Professor Marta Sitges, who will give her expert insight into how heart valve disease presents in women and what patients can do to take care of their heart health. We will hear from Jacqueline Lewis, a patient advocate sharing her lived experience, Callum Ferguson from Heart Valve Voice UK about the role of patient organizations in advocating for needed education and change. And we're also pleased to welcome Professor Gwendolina Garfina and Andressa Pereira, knowledge partners who helped develop the report's recommendations, and Karen Padilla, lead for Global Heart Hub's Heart Valve Disease Patient Council, who will discuss what these findings mean for patients and for communities. And I want to thank all of them for being here today. And with that, I'm very excited to introduce our first speaker, Global Heart Hub's very own Karen Padilla, who will help us set the scene.
Thank you very much, Joanna, for the kind introduction. And hello, everyone. I'm delighted to be here with you today as we commemorate this year's Heart Valve Disease Awareness Week and the launch of our report, Shaping the Future for Women with Heart Valve Disease. As many of you know, heart valve disease is a medical condition that occurs when one or more of the four valves in our heart, as shown on the image on the left, don't work properly. Heart valves are one-way gates at each of the points where blood enters or exits the heart. They maintain a proper flow of blood through our bodies. And as you can see on the image on the right, there are different ways that heart valves can stop working properly. Sometimes valves don't fully open, so less blood gets through. Sometimes valves don't fully close and leak, allowing blood to flow the wrong way. I know that Professor Sitges will be sharing with us more information on this in a moment. Symptoms like breathlessness, dizziness, or fatigue may not appear for years, and they may vary. The good news, though, is that your doctor can hear this murmur with a simple stethoscope, and this is the first step to detecting heart valve disease. There is an important difference, though. While all patients with heart valve disease can face barriers to evidence-based and equitable care along their journey, it's crucial to highlight some specific challenges that women with heart valve disease encounter compared to men. That's why we decided to develop this consensus-driven multi-stakeholder report to successfully improve the outcomes for women with heart valve disease. To give you some background, this work has been led by the Global Heart Hub Heart Valve Disease Patient Council, bringing together 28 patient organizations from 22 countries. There is growing momentum on the topic of women and heart valve disease. Recent publications have highlighted how differences in women need to be considered in the detection and treatment of heart valve disease. Updated ESC guidelines on heart valve disease that were launched last month, and which are the recommendations that doctors follow for the treatment of heart valve disease, include sex-specific considerations in patients with heart valve disease. And there is also political awareness on this issue. For example, the EU Council calls for more efforts to help prevent cardiovascular disease, highlighting specifically gender disparities. So on the 21st of March this year, Global Heart Hub hosted a roundtable meeting with 22 multidisciplinary stakeholders from 13 countries. The meeting was co-chaired between a patient and a clinician and I am delighted to have them with us today. On 1st of September, we were thrilled to launch the report resulting from the roundtable meeting. I invite you to scan the QR code to read it and to learn more about this initiative. I would also like to take the opportunity to thank all experts who contributed to this wonderful resource, especially our knowledge partners from Engage Minds Hub, who are also joining us today, and will share more details about the report in a moment. The report outlines 6 tangible call to actions, along with specific recommendations to improve outcomes for women with heart valve disease. Today, this webinar will focus on action number 2, as we want to provide women and their families and caregivers with the knowledge needed to recognize risks and symptoms of heart valve disease. And with that, I'll hand over back to you, Joanna.
Thank you, Karen. I really appreciate that. Very snappy, which I appreciate as well. I really think you set the stage so well to understand why this is an important issue. Now, I am very excited to bring on screen Professor Sitges, who's going to be giving us an understanding of the clinical perspective of women and heart disease.
Thank you very much for the invitation and the opportunity to participate in this webinar and also in the workshop we made in March. So my topic will be, why should women care about heart valve disease? Karen already did a small introduction. Let me see if I can advance my slides. Yes. Karen already made a small introduction of what is heart valve disease. Heart valves are in our heart to ensure that the blood goes in the right direction, but they can be damaged due to different reasons and etiologies. And if a normal heart, this is an echocardiogram of a normal heart, and typically we see normal flow inside our heart, which depending on the direction we can see by red or blue in the echo. But when one of these valves is diseased by by several different causes, this may lead to the dysfunction of the valve. And this dysfunction leads to this appearance of a very abnormal flow that is completely different from a normal heart. And this abnormal flow, in this case, leaking of the valve, leads to an overload on the function of the heart. So the heart becomes bigger and large, dilated, and in advanced stages, it can be a failing heart. And this is why symptoms may appear, but they may appear late in the evolution of the disease. And also, as Karen mentioned, the symptoms like feeling tired, like shortness of breath, particularly if they appear in advance or in more mature people, or when you may think that this is due to aging and not to really a heart valve disease. So you need to be aware of this potential disease that you may have, and that your symptoms may not only be related to aging. And this is important. Why is this important? Not only because it may feel you tired, because the important thing is that this can shorten your expectancy of life. Indeed, this is a graph showing in a large population in the UK the survival at 10 years follow-up of patients with no heart valve disease and with significant valve disease in the red curve. So you can see that mortality, okay, the probability of dying is just double if you have a significant heart valve disease. So when scientists and physicians and all health-related professionals face heart valve disease, we always think, how can we improve the outcomes of these patients? So mainly the therapy of heart valve disease relies on interventions, different type of interventions, and there are 2 main determinants. Of course, one determinant to improve the outcome is that the intervention is good. So in this sense, we have done, as you will see, a lot of improvements. But the other aspect is that the intervention is provided at an adequate timing. Okay, so in recent years, we have had an explosion and a revolution in the potential of treating heart valve disease, not only by the established surgical techniques with open cardiac surgery to replace or to repair your valves, but to more minimal invasive or miniaturized interventions, which are very important because they have proven to be safe, to be effective, and they can treat patients even at advanced ages. So some patients that were initially denied for therapy now can be treated. This is for some patients with heart valve disease who are elderly and don't want to undergo very serious cardiac operations, and some years ago now have the potential to really have minimal invasive interventions that can effectively treat heart valve disease. And this has led to a really improvement in the outcomes of these valve interventions, making them safer and much more efficient. The other aspect, as said before, is the adequate timing of intervention. And in this sense, there is a lot we can do. Why there is a lot we can do? Because there is a very low social awareness of what's heart valve disease and the impact of heart valve disease. This was a survey that was conducted asking people, asking volunteers, what was the disease that worried them more. As you can see, cancer, Alzheimer's disease, this is really known by the population, by the general population, but heart valve disease is still a very unknown disease that has very, as shown before, a very effective and safe therapy currently. But going to the area of women, why women should care about heart valve disease? We all should care about heart valve disease, as said before, but why women specifically have to make an important attention? First, because things are different in men and female. This might be very obvious, but regarding heart valve disease, the type of disease that females suffer are different as compared to men. So typically, men have more frequently more involvement of the aortic valve, for example, while women have typically more involvement in the mitral, and also they are more prone to have some subtypes of valvular disease. For example, they are more prone to have rheumatic heart disease or even degenerative mitral valve disease, where men are a little different in the etiology of the disease. And the etiology of the cause of the disease is important because it determines the prognosis of the disease. These are other data coming from another study where you can see the prevalence, and there is, as said before, rheumatic disease is more frequent in female, as shown in the red bars here, or even degenerative mitral valve disease, while calcification is slightly more frequent in male. But this also has diagnostic implications. So the diagnosis or the thresholds or the criteria we use for diagnosing severity or the importance of the valve disease is different. It can be different in men and female. And this is something that we need to know, we need to be aware of as physicians, but also as patients. You need to be sure that your physician, your doctors are taking care of these differences. So, for example, a calcification of the aortic valve may lead to a narrowing of the opening of the aortic valve, and the threshold for defining that amount of calcium to be severe narrowing of the aortic valve is lower in women as compared to men, because usually men have more calcification as compared to women. So it's important to know these differences, not to misdiagnose this disease that can be effectively treated in the female population. Prognosis is also different, and is also different even having the same disease of the same etiology or the same cause. For example, if you look here in patients with calcific aortic stenosis, meaning calcification of the aortic valve, you see that even with the same disease or the same severity of disease, females have slightly worse prognosis. This is the survival across years for female and for men. And even if they undergo the same treatment, they undergo surgery, having a replacement of the aortic valve. The prognosis is also different. It's worse for women in this case as compared to men. And this has been shown in several studies with concordant results in the different studies. In another diseases, for example, this is mitral regurgitation. This is leaking of the mitral valve. And these are patients that were treated by repairing the valve with a device that it's delivered transcatheter percutaneously with a minimal invasive intervention. And as you can see, you have women in blue. So these women with a solid line, they were treated with the device, and they were compared with those women who were not treated with this device, with medical therapy. You can see that, of course, the device improved the outcomes, but even the response to the therapy was lesser in women if you compare the difference between men who were not treated and men who were treated with a device. So even with the same disease, treating the same way female and men, the responses are a little bit different. And this is even more amazing because these are women. This is a trial performed among women with with calcification of the aortic valve who were treated all of them with surgical replacement of the aortic valve or transcatheter replacement of the aortic valve. So similar technique, but delivered differently, one by surgery, the other by a percutaneous approach. And in this trial, it was shown that the percutaneous approach, which is called TAVI, was related to better outcomes in women. But even only treating, these are data from another study performed in women, even in another study by comparing two types of devices of TAVI, there were in this study some benefits, some better outcomes with one type of prosthesis as compared to the other. What does this mean? That females have different behaviors because of many of different reasons. And finally, there is a very important thing happening in the life of women because not all patients with heart valve disease are elderly patients. We also have it in the young, particularly in middle or low income countries where rheumatic disease is still a problem. And we have this heart valve disease involving very young ladies. And this is related also to pregnancy because, you know, pregnancy is something important in the life of a woman and has a lot to decide in the diagnosis and in the timing of the intervention and in the type of intervention. Another thing, because these things that we have been saying are things related to the sex, to the epidemiology, to probably the size of the body of women, which is a smaller, but there are other things that we have been learning in recent years regarding heart valve disease in women. And this comes from data from a European registry, which involved more than 5,000 patients across Europe and also in North Africa. And the idea of this registry was to see how concordant was the clinical practice with the recommendations, with the guidelines. We call guidelines the recommendations that scientific societies make on how to treat patients, in this case, with heart valve disease. And what was observed was that the concordance with this recommended in the guidelines was lower in women. And interestingly, these are the different reasons in which this discordance between what the guidelines recommended and what was effectively done in the patient was observed. If you look here, still there is a lot of patients who refuse to have the therapy, and look what, female are more prone to refuse the recommendations proposed by the guidelines and therefore by the attending physicians. So to sum up a little bit what all I have said, there are epidemiological and different causes leading to heart valve disease in men and women, with women having different causes of the disease and different presentation, but also differences in body size make differences in how the heart adapts to this disease and also to the interventions. And that is associated with some complication or some different responses to some therapies. But also, and very important, there are still differences in symptoms and referral biases, because women come later to consult for physicians. Women, as you saw, refuse more therapies, and when they are finally intervene, they are more symptomatically and more in more advanced stages of the disease, increasing sometimes the risk of the intervention. This is why this action led by Global Heart and this workshop is so important, with these different actions that Karen already highlighted and that will be developed with the following speakers. Thank you very much for your attention.
Thank you so much, Professor Sitges, for such an informative presentation. You've given us crucial insights into how heart valve disease presents in women, but also why early detection and appropriate care are so essential. And with that, I would like to now introduce Jacqueline Lewis, who we are very grateful to have with us. Jacqueline, I'm going to bring you up on screen with me. Thank you so much for being here. Would you mind introducing yourself for us?
No, it's a pleasure to be here with you, Joanna, and the rest of the panel. So my name's Jacqueline Lewis, as Joanna said. I am a heart patient. I've had open heart surgery, and I'm here to talk a bit about the experience that I went through. So thank you. So I'm 64 years old, and at the age of 11, I was diagnosed with a heart murmur, and it was pretty non-eventful. I, was having fainting fits at school, and if I stood up too quickly, I would pass out. And if anybody was going to faint in assembly at school, it was always me. So mum took me to the doctors, and the doctor said, well, she's got a heart murmur. Nothing else was done. I think they possibly listened to my heart. I can't remember what else happened. But it was pretty uneventful, as I say. So I went through life working. I've got a family. I've got 2 children who've got children of their own. So I've got 5 grandchildren. I worked as a nurse for many, many years, and eventually ended up working in the pharmaceutical industry as the director of ethics and compliance. So busy life, busy working mum, busy in all ways. Family's always been busy, and everything was fine until really, I would say, I started to notice some changes to my health probably about 2 years ago, and had the surgery last June. But the year before that, I started to notice some breathlessness and just some different feelings that I was getting in my chest. And at the time, I'd just lost my mum. So, I was grieving. I was feeling, not quite myself. And I was finding the journey to work. I was working in London and having to travel on the train every morning for about 45 minutes to get into the office, sometimes over an hour. And I was finding it more difficult. And a couple of times, I would find myself having to stop when I got off the train. I would have to stop and like catch my breath, and felt really quite not quite faint, but just realizing that there was something going on with my breathing that wasn't normal. And I remember walking and my boss caught me up one morning, and I was walking along, and my boss came up behind me. Hi, Jacqueline, and we started to walk together into the office. And I became so breathless that I thought, please, can you go away? I feel I'm going to collapse or something. But I managed to get into the office. And it was the start of symptoms that I didn't know what they were. So, my story takes me further into that, Joanna, in as much as I spoke to some doctors that I worked with, and they were like, well, not sure, and I went to my own GP, and they said, well, it's probably anxiety or menopause. And I was thinking, well, it can't be menopause, because I had a hysterectomy at age 46, and I was past that in my life. So I grew more and more anxious, wondering what the heck was going on, really. So that gives you a bit of a first taste of the picture of my patient experience.
I really appreciate that, Jacqueline, you sharing your story with us, but also some of the barriers you've come across. I'd actually like to touch a little bit on something you brought up, which is the challenge of getting a proper diagnosis. It sounds like you've had some experience with that. Can you tell me a little bit about that challenge, about getting the right diagnosis, and what advice you might give to other women who are facing a similar challenge?
Oh yeah, absolutely, Joanna. It's one of the big issues that I like to talk about, is the challenge I had as a a woman of my age, or any women who are facing health challenges, but particularly with this, I went to my GP. And they said, oh, well, I wonder if it's anxiety. You've just been bereaved. You're working hard. Blah blah blah. But I said, I thought it was more, and so they actually sent me to a cardiology clinic in the local hospital, and I had various tests done. I actually had an angiogram straight away, without, I was wondering what on earth was happening, really, when they were doing that. And I was really poorly. My blood pressure was so low. On that day, I felt so, so unwell. And then I got a letter from the hospital saying, all clear, nothing's wrong. And I thought, well, that's really weird. So, I contacted them. I had so many calls trying to get through to the cardiology department to say, why, you've discharged me from care. I've still got severe breathlessness. And it got so bad that I actually stopped working, Joanna. I had to stop working. I couldn't do the journey each day. And I was really struggling. And I've worked all my life and I loved my job. I didn't want to give it up, but I found I had to. So, I would say at that point, I was pretty desperate. And I decided that, with the challenge that was in front of me, the only thing left for me to do was try and find a private cardiologist and go to them and, get some real advice, which is what I did.
What you're saying is unfortunately so common among women, this idea that they're going to see their clinicians for help, but they're not getting the help that they need. And I think your story is a really good illustration about how it's not just one appointment, or it's not just being pushed off one time. It's a series of events that leads to things like having to step away from your work. It has impacts on people's personal lives, emotional health, and it really does ripple out to somebody's broader life. And I really appreciate you sharing that side of things with us. And also the advocacy that you did for yourself to get you to the right doctor who would give you the correct diagnosis and put you on the path to healing. So I really admire
Mm,
everything that you've done and having that example of advocacy for other women who may be, struggling to get a
absolutely.
diagnosis.
Yeah.
And if I can ask kind of as a follow-up on that, sort of looking back at your journey, sort of on the other side of things, is there anything you wish you had known earlier about heart valve disease as a woman, something that other people might value learning at this
Yeah.
stage?
Well, the interesting thing is, I mean, I mentioned at the beginning that I'm, qualified nurse, and had worked on medical wards and seen many, many patients with cardiology concerns. But I think as I think most, I don't know whether it's just my generation or what it is, but I think, most of the things you hear and find out about cardiac symptoms are related to men. So my experience was nursing men who'd had heart attacks or, other cardiology events. And even despite the knowledge that I had, I didn't really know much about women's heart health. And I suppose I wish in a way that I had, that I had considered that because, in having the challenge of trying to get my own diagnosis, I just didn't really think about what it could be. And I would say to anyone going through a similar challenge is not to take no for an answer because, you will get a diagnosis in the end. I had to use the private consultation, and immediately the cardiologist listened to my chest with a stethoscope. So a simple stethoscope check, can show so many things. And he immediately said, you need open heart surgery. And I was like, wow, I can't believe this. But that's what happened. It turned out I was born with a bicuspid aortic valve rather than a tricuspid valve. And I was at the severe stage of aortic stenosis and needed surgery pretty quickly, which was within 10 to 12 weeks, I had the surgery. So I would say, to any women, really look at what's available out there as knowledge checks. And I would say, Global Heart Hub and Heart Valve Voice have so much information available that I've actually shared with other women now because it's invaluable to try and get a diagnosis.
Absolutely, and it sounds like your advice to not take no for an answer is so important for so many women. We're here to be in
Absolutely.
collaboration with our healthcare professionals, but also sometimes women have to say, I know something's wrong, and I'm going to find the information and the help that I need to figure out what it is.
Yeah.
So I want to thank you for sharing your story with us. You're going to stay with us for the full panel, but I'd love to bring our other panelists up on screen now so that they can introduce themselves first, and then we're going to get into some questions. So I'm going to first ask Callum from Heart Valve Voice UK to introduce himself.
Hi everyone, I'm Callum Ferguson from Heart Valve Voice UK. We are the UK's dedicated heart valve disease patient organisation.
Thank you, Callum. Really excited that you can join us. Andressa, would you mind introducing yourself as well?
Well, I'm happy to be here. I'm Andressa. I'm researcher at Engage Minds Hub at Universidade Católica, and I've been working with all the team in Global Heart Hub with the scientific support for the report.
Wonderful. And last but not least, Professor Gafinia, if you could introduce yourself as well.
Yeah, thank you very much for inviting me, and I'm honored and happy to have been a scientific partner of such an important initiatives. I'm a full professor in consumer health at the Università Cattolica, where I direct Engagement Hub, that is a research center dedicated to patient engagement.
Thank you so much for your introduction and for all of you for being here today. I have some questions that I'm hoping to dive into with all of you. I might start with you, Professor Graffinia, because you were such an instrumental part of this report that has come out. I'm wondering if you might be able to tell us a little bit about this issue of underdiagnosis, late diagnosis, undertreatment of women with heart valve disease. From your perspective, what are some of the key reasons that this continues to happen?
Many reasons are the economic, demographic, social, and psychological level because still women are diverse as the other patients, and this means not only at the biological and hormonal level, but also in terms of their societal role. Women often are the main carers, the main caregivers in their family. They take care of their partners, their sons and daughters, of their parents, but they forget to take care of themselves. So even though women are often very proactive in prevention, in screening for their beloved, they tend to dismiss the awareness of the early symptoms or fatigue or some discomfort that they may experience both at the physical and the psychological level. And so this is the principal factor from my perspective that hinder an early prevention and also an early detection of women heart valve diseases. And this is due not only because of the motivation of the women, but this is due by the societal structure in which women are inserted. And this has also differences across culture. In some countries, in some groups, this is even more evident, in some other less. But still, there are a lot of stereotypes, gender biases, also in terms of how much women are able to face and cope with fatigue, with pain. So the ability of women to support pain, to accept pain is often very high. And also because women feel guilty of disclosing difficulties. So all those elements that I briefly represented show how much sociocultural, psychological, emotional fact that appear as less important than the biology of the heart, but from my perspective as a psychologist and also an expert in public health, actually in the case of women heart valve are the main factor that should be taken into consideration if we want to develop, first of all, a broader awareness of the importance of an early prevention and an early detection. Then there are also some pragmatical factors related to economics and to the cost of prevention, because often this imply losing some days of work, taking the car, getting involved in the information, paying for visits, and again, there may be a lot of differences across different healthcare systems. And so these imply an inequity of the access depending on the sociocultural level of the women.
Absolutely. Well, thank you for such a comprehensive answer. And really, what I'm taking away from this is that there are so many different factors that can play into this delayed diagnosis and undertreatment of women with heart disease. We're talking about biological factors, cultural, social, financial, emotional. And so it really is so important to understand how all of these things interplay together so that we can start to tackle some of these barriers and get women diagnosed and treated in a timely way. With that, we know in this landscape of a lot of different barriers, Callum, I'd be really interested to hear from you as somebody who helps lead a patient organization. What strategies have been effective in reaching the patient community to help them better understand heart valve disease and seek timely care?
Thanks very much. So that the main strategy for us is patient stories like Jacqueline's. These peer voices always resonate more with people. Earlier this year, Jacqueline went on the radio for us on Women's Hour, which is a very popular radio show in the UK. She went on with a clinician to talk about her story and some of the risks and challenges women face in getting diagnosis and treatment. And the feedback from it was incredible. I mean, within hours of Jacqueline being on the radio, we had dozens of women contacting us, wanting to advocate for other women's and women who didn't even have heart valve disease, you know, which very rarely happens for us. This was just women who wanted to support other women. And I think that is another part of the awareness and advocacy strategy is finding these stakeholders, maybe outside of our usual remit of health stakeholders, finding these women organizations who will amplify these messages for us. And that can really build awareness.
That's such an excellent way of looking at it. And I can't say I'm surprised to hear that Jacqueline, her voice is being heard in so many places because she's such an excellent advocate. But also, it is really interesting to see, with all the really difficult and complex barriers to a timely diagnosis, sometimes the solution is really about going back to these personal relationships patients and communities have with each other, sharing people's voices, and seeing what a real difference that makes. So I really do appreciate that perspective. Now, I kind of want to tackle something that Professor Graffinia brought up in this kind of list of barriers that we need to tackle, which is sort of this social determinant of health. So things like income, education, geographic location. Andressa, I'd be curious to know from your perspective, how do these things influence women's access to diagnosis, but also what is there to be done? How might we start to tackle some of these barriers?
Thank you, Joanna. We have seen in this report that we have a lot of cultural and social demographics and also geographic conditions that are different. We have a rheumatic disease and also we have other kinds of disease. And I think that for the report brings something very important, that are actions that may be adapted according to these cultural and also social demographic conditions. We have some actions focused on these screenings and also some technology that may be used to reach people in remote areas, and also these kind of actions that can improve and also have these equitable access for most women.
I really appreciate that. And something I'm kind of taking from this is that there are things that can be done. Sometimes the problem can seem very insurmountable when we're looking at everything from geographic location to culture to biology. When we look at so much, it can feel insurmountable, but we know that it's not. There are concrete steps that can be taken so that women and all patients can get the care that they need. So I really appreciate that. I'm also kind of curious to hear about, we've heard a little bit about the barriers to women recognizing their own symptoms. So on that line, Professor Sitges, I'd be curious to know if there are any specific symptoms or presentations of valve disease that women or even clinicians may overlook. So do you have any perspective on that?
Yeah, thanks for the question. The problem is that this is a progressive disease, chronic disease, that leads to very progressive symptoms, and they are not specific, okay? And they are not probably specific in both genders. So, but what is true is that women, as I said before, try to seek later for help, and they are many times confused by anxiety, this shortness of breath that is very typical from heart valve disease, but it's completely unspecific and can be related to other diseases, even anxiety. So many times is more misdiagnosed in women as compared to men. So I would say that probably that's even chest discomfort in a man usually triggers the alarm of heart attack, while in women many times is still misunderstood as something like anxiety, and women are more prone to cry, and then they come to the emergency crying, and they are many times misunderstood. So, I mean, I want to highlight what Jacqueline said, no? I mean, we in the era of technology and advanced imaging and, high-tech hospitals, we try to forget on very simple things like listening with your stethoscope. And that can be done in many places in the world with no cost almost. And it's really important for heart valve disease. So really having a regular check with a stethoscope cannot diagnose all heart valve disease, but the big amount of it, yes. So please ask for it and in your community.
Yeah, that is such an important point, which is that the symptoms of heart valve disease can mimic or imitate other conditions, and people go to their doctor and they say, no, you have anxiety, no, you have asthma, but really they are walking around with something that needs treatment and needs to be diagnosed properly. And that kind of brings me back to you, Jacqueline, because you did touch on this idea of symptoms that maybe aren't immediately recognizable, but you know, perhaps have an idea that something is not right. So I'd be curious to know your thoughts about the presentations of heart valve disease, what you want women to know, but specifically, what message would you share with other women who may be ignoring their symptoms or hesitant to seek care when they're trying to brush it off and be like, I don't have time for this, or I think it's just anxiety? What message would you have for them?
I really would say it's so important to get your heart checked, because I think it was I think Marta, I think you touched on something earlier when you were saying that women can tend to get more emotional about things than men, and can turn up crying, and it can be so confusing, but the symptoms are serious, and the breathlessness is not just like you've just been for a run and you're out of puff. It's a different sort of breathlessness, certainly what I experienced. And I see in the chat there that Rachel has put, it's interesting how asthma and heart valve disease can be mixed up. And that's so true, because I also suffer with asthma. So, but I would say to women going forward, as I said earlier, please don't take no for an answer. And you want that differentiation. Is it asthma? Is it something else? Or is it actually your heart? And that stethoscope check is just such an easy way as a first stop. I hope that answers the question, Joanna.
No, absolutely. I think what I'm getting from what you're saying is that if you're in front of a doctor with these symptoms, sometimes you have to take the extra step instead of saying, I have breathlessness, to saying, I have breathlessness, can you check my heart? Sometimes you have to just put it that plainly, because they might have an instinctual response to say, anxiety or an asthma. So let's put it in front of the doctor and say, can you check my heart? Because it can make all the difference.
Absolutely. And I wish I'd have thought of that at the time when I was going through my symptoms. So I would encourage any woman to do that now.
Thank you, Jacqueline. And hearing from you brings me to another question, and I'm hoping, Professor Graffinia, you might be able to weigh in, which is the idea of the patient voice and how it shapes how we move forward. So I'm curious to know, how did the patient voice help shape the development of this report's recommendation, and what role does that play when you're trying to address gender gaps in care?
I think the patient voice was crucial, and it is crucial and will be crucial. First of all, because the initiative of this report came from patients. Second, because in the consensus, the patient participated in a very active way together with other experts, because in our consensus, patients were experts as well as researchers, as well as clinicians, but with a different kind of expertise. They are experts of their diseases, whereas professors or doctors or clinicians are experts at the technical level for the knowledge about the biology of the disease and the drugs and the treatment. So patient voice, it's very important because can be a co-pilot in the development of any innovative initiative, and I think are crucial in order to point at the problem, point at the hindrances to apply potential solutions. So I don't think patients can find themselves the solution. and this won't be safe, but they should point at the problem and should point at the situation that may hinder any kind of solution. And then on the basis of this, collaborating with the experts, the technicians, then we can find the best balanced and innovative problem solving and solution.
Absolutely. I was actually curious to know as well on this side of patient involvement and patient voices, Callum, I might be able to ask you what kind of role patient organizations and advocates can play in closing this gap for women in diagnosis and treatment. What do you see moving forward?
Well, I think fundamentally, patient organisations are here to amplify women's voices in this scenario, use and allow them and empower them to use their lived experience. I always think that we can kind of like bridge the gap between that lived experience and policymakers. And we can also hold them accountable. So I recently did some work on an NHS inequalities charter, which is great, you know, and there's a big section on that in gender, but it's meaningless if at the end of it we create the charter and we kind of pat ourselves on the back and put it on the shelf and nothing happens. You know, we need to know that in 6 months, 12 months, 3 years, what's happening with that. And if nothing's happening, we need to shout about it and enable and empower women to do that.
Absolutely. And you've kind of brought up another thing for me, which is this role that patient organizations play with their own communities, but also this role of trust when it comes to education and getting the right, information that patients need. So I would be curious to know in the role of clinicians and their patients, Jacqueline, from your perspective, what makes a trusting relationship and how can we build that into the expectations for patients so that they can get the care they need and they can feel comfortable and confident asking for it?
I think, to be honest, having that open relationship with the clinician is so important. I think it's probably, if you've gone through an experience where you've not had a good time in your initial consultation, etc., it's trusting the professionals who are using the right language with you. I think you've got to be open. You've got to speak to your own truth. What's going on for you? How is it affecting you? And taking up the cues from the clinician as well, in as much as taking that next step forward and discussing what can be done. Ask questions. And I think, in my experience, asking as many questions as you can, I got a real picture of what the diagnosis was, and then was able to look into it more and do my own research.
Absolutely. Professor Sitges, I'd be curious to know from your perspective on this question of needing trust between healthcare professionals and patients and how that facilitates early detection. How do you see that playing out from the clinical side of things, and what might clinicians do to help build some of this trust?
Well, it depends. That's a difficult question to answer simply because it depends a lot on the setting of the healthcare. The important thing, in an ideal healthcare, for sure, trust is essential. You need to trust your physician, otherwise it's difficult to have this relationship. But the important thing, I think, is that we are really, as patients, are really well informed in all the options and in all the potential diagnoses. So increasing the accessibility for diagnosis, increasing the information for a given therapy, because in reality, in an ideal world, all patients should have same opportunities, but we know that sometimes it's not this way. So this is something to empower patients also, and I think it's a very important role for the patient associations to make these communications among patients, not to make their gain and confidence for the health system, but on the other way around. To really seek for the most comprehensive and to keep the whole information, and then you will see that probably your physician made a good recommendation. But it's important because this is also an evolving field. and things are changing rapidly. So fortunately, we have significant developments and more to come in both terms of diagnosis and therapy and safer interventions. So I think it's also good for patients to have this empowerment, and not as a sign of not trusting your physician, but just wanting to have all the information and understanding your process, because it's your body, it's your process, it's your life.
Absolutely. I think it's a really interesting point, which is that, comprehensive education and information helps patients feel empowered. It helps them come to the table and have an open conversation about what treatment looks like. And having an open conversation with a physician can really help build their own confidence to advocate for themselves, helps them feel more invested in their journey, and I think it can make an incredible difference. And that is kind of a two-way street where clinicians and patients are coming to the table together, and that makes an incredible difference as well.
And you could be amazed on how patients find information in the web now. I mean, information is everywhere. The problem is the quality of information. So this is why it is important to have a solid source of information and something that can be reliable. Because if you look in the internet, you just become crazy on what's the information there, and you really don't know what to trust.
Absolutely. It's hard to evaluate what is out there when there is so much information. And I think that's where patient organizations like Heart Valve Voice UK really come in to help guide people to the right information, to help put things out there that are trusted and backed by scientific information. Absolutely. I would agree with that. Andresa, I might ask you a question as well, and then I'll probably finish it out with one last question to Karen. How do you envision these recommendations being taken forward in real world policy or practice? What would be sort of your vision for this?
Well, I think that summarizing all that we mentioned here, these recommendations, they are trying to educate, empower, and engage. So I think that is a collaborative work with the healthcare professionals and all the stakeholders, and the patient voice, the women's voice are very important. So with this power, this collaborative work and this collaborative work with all the stakeholders, it's important to go through, as Callum said, and to go to the policymakers and all these institutions to show this important role that is highlighted here, and all this material that can embase these recommendations. All the recommendations are done with a way that can be implemented, and then all the stakeholders can work together. I think that is a society, all the policymakers and also the healthcare professionals and patients working together to get this.
Absolutely. And I think what I've really also taken away from today is that advocacy to change this is going to have to happen at every level, down to communities to help build awareness, down to patients to advocate for themselves, for clinicians, all the way up to collaborations between patient organizations, policymakers, clinical societies. We all do need to sort of play a part to help close this gap and get women the care and the treatment that they need. Now, I have one last question for Karen. Just to close this out, I would love if you could share just the key messages or calls to action that you hope patients and advocates and everyone in our audience can take away from this webinar.
Thank you very much, Joanna. And first, I have been enjoying this conversation so much. It has been incredibly rich. And I think a lot of the key messages from the report have also been highlighted here. And one of them really is that we need to work together. We need to collaborate together. And I think this webinar is a great example of how multidisciplinary work can be done, and that we need all the perspectives really to improve the outcomes for women with heart valve disease. And if you are a patient, I really encourage you as well to reach out to your local patient organization for support, for peer-to-peer support, to really hear the stories, and to also have access to really valuable information that might help you in your journey, because this is a journey. And as part of that journey, we also need to make sure that we as patients have the opportunity to sit at the table as equal stakeholders. And I believe something that Professor Sitges mentioned, and also Jacqueline, And Professor Grafinia, the importance also of patient engagement, of shared decision-making, of having your voice heard. And if you don't feel like your voice is being heard, like seek for another option, seek for another opportunity, for another opinion. And this is your journey as well.
Thank you so much, Karen. I think that's an excellent way to sort of close us out. This is their journey, and that they have the opportunity to use their voice and to be heard is so critically important. And if you're not being heard, find somewhere else because it needs to happen. So we only have a minute left. So first, I want to thank all of our panelists for joining us today, sharing their time and their expertise with us. I got a lot out of this conversation, and I'm so grateful for all of you to be here and to share this with our audience. I'm also very grateful to have been able to partner with Heart Valve Voice UK and Callum on this webinar, who brings in a wealth of experience and expertise in this. Thank you as well to everyone in our audience. I hope this was valuable for you, and I appreciate you spending this last hour with us. You should see a survey for this webinar after exiting, which I hope you'll take the time to fill out. We always want to improve. I'll also note that we will be sending out a recording of today's session to all attendees. It might just take a week or so to get out. For anyone interested in learning more about our work, I encourage you to reach out to me. Thank you again, and I hope to see you at our next webinar. Bye, everybody.